Chapter 11 Exam Technique Specific Examples. Overview. This chapter first describes the range of assessments used in medical education and then applies the general rules covered in Chapter 10 to specific examples. Note that although there are some very good general books available on exam technique in higher education, it is hard to find any that provide useful advice on the range of assessments used specifically in medical courses. Each medical school seems to add its own flavor to its assessments. So supplement these rather generic pages with discussions with the other students in your year. Those in the years above, any past papers in the library, and any friendly faculty members that you come across. Introduction. It would be rather dull to punctuate each paragraph with a disclaimer, so here is one reminder that good exam technique helps you to effectively demonstrate what you know can do. It does not in any way replace the fact that you need to have learned the content first. You must also remember from the first section of Chapter 10 that you should make every effort to find out the exact format of the exams at your school. As you will read below, everyone has their own specific variations based on common themes. Types of exams. Multiple choice exams. By multiple choice exams, we refer to any assessment when you are asked to choose between different options in order to demonstrate that you know something. These are popular exams, not least because they are easy to mark using automatic systems, such as optical readers of mark sheets and even direct entry exams where you interact with a computer. Examples of different multiple choice formats are described. True, false items. Each item is independently marked as either true or false. These are generally less popular in medical education as they tend to test regurgitation of simple facts rather than understanding, and tend not to appreciate that there is often not a single answer. Some schools still use them quite a lot. Example: true, false multiple choice question. Q7 with regards to diabetes. Insulin resistance is commoner in type 2 than type 1 diabetes. B. A single fasting blood glucose of greater than 5.0 is diagnostic. C. Women who develop diabetes in pregnancy are more likely to develop diabetes in later life. Best of 5. In these questions, you are asked to choose from a list of 5 items and choose the one which is most true or most relevant to the reading of the question. This allows for uncertainty and some degree of judgment. Q8 gives an example of how some simple true, false questions can be converted to a best of 5 format. In Q9, both items B and C might be true, but B is less clear, more debatable than C, so the correct answer is C. Example: best of 5 format. Q8 with regards to diabetes, which of the following statements is true? Insulin resistance is commoner in type 1 diabetes than type 2. B. A single fasting blood glucose of greater than 5.0 is diagnostic. C. Women who develop diabetes in pregnancy are more likely to develop diabetes in later life. Q9 with regards to study skills, which of the following statements is most true? Drawing a mind map is only possible if you have A3 paper. B. The Cornell method is best used in lectures. C. It takes about 3 months to learn a new study skill effectively. These study skills tend to make little difference to performance. E. Copying out chunks of text from a textbook is an active learning technique. Extended matching questions. This format of questions is becoming rather common in medical education. Each question has a general topic followed by a range of possible answers. The student is then presented with a number of question items, and they need to select one answer for each item from the list of items. Example of extended matching questions. A true, false multiple choice. B. Best of 5. C. Extended matching questions. D. Short answer questions. E. Essay questions in an exam. F. Non-timed essay questions. G. Objective structured clinical examination. H. Viva voce examination. I. Portfolio based assessment. J. Computer marked assessment. K. Blood test. Each of the descriptions below relates to a different form of assessment. Choose the single most appropriate answer from the list above. Q. Can a student who graduated in the 1980s sat this knowledge-based exam and had to select whether each of 600 items relating to basic and clinical sciences were true or not? Q11. A medical school decides to replace the traditional assessments in the final year with this method that requires students to collect evidence from a wide range of sources to demonstrate that they have the required attributes to graduate. This format allows examiners to ask some reasonably probing questions to try and assess understanding rather than just knowledge and even some problem-solving skills. Written exams, essays. Essays will be familiar to all students. At medical school, you will be required to write some essays, certainly as assignments within coursework, and still in some schools as part of formal exams. Essays are tiresome to mark and can be challenging to mark fairly. As a result, they seem to feature less often within medical school assessments, and when they do, students can feel unprepared. We have not included a section on essays in this chapter, but have included some information on essays and academic writing in Chapter 6. Short answer questions. These questions ask students to write in free text what they know about a subject. Questions are usually structured and very focused, and answers are usually given in note form as shown in the example in the Chapter 10. Some institutions give single questions, others break a question down into subparts to help structure the answer. The marking scheme is usually very apparent, and candidates usually write their answers directly on the question sheet, including any rough working. Q12 describes the initial clinical presentations of myocardial infarction. Q13 describes the classical acute symptoms of a myocardial infarction. Describe the key findings likely on examination of a patient suffering from a myocardial infarction. List the principal initial investigations required to confirm a myocardial infarction. Clinical exams. If you are to graduate as a doctor, clearly it is important that you will be able to demonstrate that you can apply your knowledge and skills directly with patients. Traditionally, this was tested through long and short cases. Long cases where you saw one or two patients, took their history, examined them and tried to work out what was going on before presenting your findings to the examiners and answering questions, and short cases where the examiners would take you to see bits of patients to see if you could spot what was going on. On one session, you might see 3 different sorts of arthritis of the hand, listen to a couple of different heart murmurs and feel a lump in someone's abdomen, or with barely time to even introduce yourself to the patients who were attached to these various clinical signs. These exams had their strengths, but unfortunately 2 students might have a very different experience, with one perhaps having easier patients than another. Long and short cases have largely been replaced with objective structured clinical examinations. Imagine a big hall with 24 booths around the walls, 6 on each side. Each booth tests a different skill. In booth or station 1, a student might be expected to take blood from a rubber arm. In station 2, a student might be expected to ask a patient about their chest pain in order to come to a diagnosis. In station 3, perhaps students examine a patient's arthritic hands and so forth. 24 students stand there, 1 in each station, and spend a specified time in each one, and at the 5-minute bell, each student moves on to the next station, apart from the student at station 24, who moves to station 1. After 120 minutes, every student has done every station, and the exam is over. Every student has had the same experience. Add some variations in timing, in design, and in location, and you have an OSCE. Fair because every student gets the same experience. Safe because a wide range of skills are tested, so unsafe students don't slip through unspotted. Incredibly dull for the examiners and either quite fun or absolute torture for the students depending on their perspective. Love them or hate them, OSCEs remain the gold standard assessment of clinical competence and look set to remain so for a while yet. Clearly, OSCEs are not very realistic, and as a response to calls for assessments that truly assess what people can and do in the real life care of patients, various work-based assessments have been proposed. The most widely used in the UK is the mini clinical evaluation exercise. There are a multitude of variations in this theme, but simply put, the candidate performs some kind of task, usually with a patient, and is observed and marked by a senior using a semi-structured pro forma. Over the months and years, they are observed by many different people while performing many different clinical tasks with many different patients, and an overall picture or judgment can be made about the learner's ability. The advantage of the mini CEX is that it is used in a real-life setting, and that the assessor can give rapid feedback to the learner to help them develop. As you might remember from Chapter 3, this doesn't often happen in the clinical environment and so has to be a good thing. On the downside, the original mini CEX form is probably a little too generic for DKL. Focused feedback in junior learners, and there have been some issues with actually getting people to fill them out. Oral exams. Oral exams are part of the history and tradition of medical education, and one way or another you might find yourself receiving a viva voce exam at the hands of 2 or 3 examiners. Institutions now tend to reserve these assessments for students at the borderline or students who might be worthy of a prize, although many have scrapped them entirely. If you take an intercalated BSc, you are still likely to have a viva on your thesis. Traditionally, this form of exam has been received with terror from the candidates. The format is rather elegant. The examiners ask the student questions about a topic, with each question more difficult than the last, until they ascertain the upper limit of the candidate's knowledge on that topic. They then move to another topic and work up the ladder again. Within a relatively short time, they can build a picture of the candidate's depth of knowledge out of a range of core areas. Unfortunately, the frustrated candidate, regardless of whether they were good or bad, leaves the exam remembering only that they got the last question of every topic wrong, and so tends to feel terrible. Variations on a theme. So far in this chapter, we have tried to give an overview of the main assessment methods. Of course, there are many variations, and the exams at your institution might be different. The OSCE, for example, looks a little different wherever you see it, and indeed sometimes people will take the OSCE concept and apply it to something else, such as an anatomy spotter exam, where students rotate around anatomy specimens answering questions, or data interpretation exams where students rotate around radiographs. Urine results, blood test results, etc. Generally, people rename these exams anything that sounds like Osler, Os. If you have a bored moment, try to make up some OSCE like acronyms yourself and put them into PubMed. You are likely to find that someone else has come up with your acronym already. Similarly, mini CEX, SAQs, and good old MCQs have all given birth to a multitude of variations. Our call from Chapter 10 remains: ensure you understand the assessment program at your institution, what it involves, what format it is in, and what purpose it has. Getting the best out of multiple choice exams. MCQ exams, whatever the format, tend to strike fear into students' hearts. There are some simple rules to follow, though, which will make life much easier. Manage your time effectively. Use time posts. Start the exam by looking through the question paper. Check the number of questions and how much time you have for the exam. Work out how long you have to spend on each question, and write next to every 10th question what time it should be when you reach that question. If you have already done most of the calculation before the exam, this should take less than a minute. These time posts will quickly flag up to you if you are running behind. If you are filling in an automated marking grid, use these time posts as a reminder to check that you are still marking the question that you think you are marking. It is easy to skip a question and then all your answers refer to the question before or after the one you think you are answering. From personal experience, it is much better to discover that you have gone wrong early than when you get to the end of the exam. There are no traps. If you are looking at a question not sure whether it means what it says or whether there is some secret second meaning in it, just go for what it says and move on. Having said that, beware the double negative question. These are questions of dubious value that act as both a test of knowledge and a test of supreme logic at the same time. In Q40, double negative answers are difficult to answer, so the statement in A is false. And the question asks us which answer is false, so we highlight option A for obvious reasons. Most schools will now be avoiding double negative questions, but one or two will sometimes slip through the net. Just go back to basics, look at the question, put a box around all the relevant words, equates to stays the same or increases. This statement is true, and so we don't select it. Q14, one of the following statements is false. Double negative questions are not difficult to answer. The most liver enzymes do not fall in patients with hepatitis. Sometimes there will be badly written items that might help give you some clues. Look for items that are much longer or shorter than their neighbors, and remember never is always wrong. Always is never right, which is, of course, only a rule of thumb. Very little in medicine is definite. So in Q16, you don't need to know much about items A, B, C, and need to guess that they are false, leaving only item D is the correct one. Q15, one of the following statements is correct. The gene for cystic fibrosis is usually found A on chromosome 1, B on the X chromosome, C on chromosome 5, D on chromosome 7, and is responsible for coding for a regulation protein controlling ion and fluid flux across cell membranes. E on chromosome 8. Q16 with respect to chest pain. A cardiac pain never radiates to the right arm. B cardiac pain is always described as crushing. C esophageal pain is always burning in nature. D indigestion can sometimes resemble cardiac pain. E costochondritis never presents as pleuritic chest pain. Similarly, when answering EMQs, often there are not 11 or so good options. So the examiners might need to put in some clearly spurious ones. In Q10 and Q11 above, item K blood test is clearly pointless. And indeed, some of the items clearly relate to very different sorts of questions. Clearly, questions about written exams could not possibly relate to a viva voce, for example, which narrows your choices. When answering EMQ questions, there is a process to go through. First, read the step. What is the question about? Let's read the question and see if an answer pops into your head. For question 10, you probably knew the answer was true, false, MCQ. Now look through the options. If it is there, write it down. For question 11, you probably didn't know the answer initially. So in this case, you look through the options and see if the right answer is obvious. If you are still stuck, go through mentally or physically crossing off the answers that are clearly wrong and see what you have left. Figure 11.1 Process for answering extended matching questions. The most common mistake that students make with any form of multiple choice exam is with their preparation for the exam. You will find a multitude of multiple choice questions in books in the library and even more badly photocopied. Barely legible lists of questions that someone you know has a friend who got them from someone who swore that they were real exam questions from some long distant year. The mistake that people make is trying to memorize every question they come across. Your memory will not be able to hold all these questions, and given a whiff of adrenaline in the exam, you will find that you can remember seeing the question before, or at least a question like it, but the answer, that's another question. This will lead to confusion and frustration. Even if you do have everything memorized, the chances are that the questions will not be identical to the ones you learned. Past papers and external questions are really useful if you use them in the right way, namely for two functions. First, use them for timed mock exams to help you get used to the format and timing of the exam. Second, use them as a diagnostic tool. Look through your answers, and when you get a question wrong, jot down the area that it relates to. If you get a couple of questions on similar topics wrong, that highlights the need for you to go back to your notes and revisit those topics. Remember, don't try and memorize answers to questions. Go back and try and understand the topic. Getting the best out of short answer questions. Our discussion of Q3 and Q6 in Chapter 10 highlights most of the key points about answering SAQs. Read the questions carefully. Box or highlight the key points and answer, providing as much structure as possible to highlight the key points in your answer. You might consider counting out the answers. It is likely that if there are 3 marks for describing the key findings likely on examination of a patient suffering from a myocardial infarction, then the examiner is looking for 3 main points, unless, that is, the mark scheme gives half a mark for each main point, expecting 6 main points. Despite this difficulty, looking at the marks should help you structure your answer. If there is only 1 mark for a definition, then you might write a little less than if there were 5 marks for it. We have already discussed the critical importance of strict timing and that you should answer every question that you are supposed to answer. We have also commented on planning. It is worth spending a minute or two planning out your answer. Most schools would encourage you to include your rough plan in your answer, putting a single line through it to show that it is rough. If you run out of time, it might still earn you 1 or 2 marks. If you read Chapter 2 carefully, you will have a good idea of how to prepare for this form of exam. You can build writing your own questions into your day-to-day note-taking and practice answering them as a way of reviewing your study. You will, of course, want to have full-time practice exams, but you should be very well prepared. Perhaps you will use a blend of your own questions and external ones. Perhaps you could share your questions with other students and build up a study group. It is quite easy to test factual recall and even understanding with SAQ papers. It is much harder to write an SAQ that tests the more advanced skills that we discussed in Chapter 2, such as application, analysis, synthesis. It is possible for very skilled question writers to try and test these higher skills, but more often than not, these will be kept for other formats such as debates, beavers, and of course the essay. Getting the best out of the OSCE. It is likely that whatever your background, you will have had a fair amount of experience of a range of tests, but the OSCE is likely to be a new and rather daunting format. For this reason, we have added a rather generous section on OSCE performance. The aim of the OSCE is simple. Imagine a geologist drilling down to take multiple core samples of the underlying soil and rock. At some point, he or she can say that enough samples have been taken to be able to build up a likely picture of what is underneath. If enough samples show clay, the underlying soil is likely to be clay. In the OSCE, the concept is that an individual will demonstrate through multiple samples that they are competent across the breadth of necessary skills, so that the exam can infer that they are probably competent across all skills. The aim of the exam, therefore, is to assess clinical competence, whether you will be any good at the job. Students who strive to develop as good doctors, to learn the knowledge and skills required for the job, to become good at patient care, should pass the OSCE easily. Unfortunately, some students see the OSCE as some kind of higher education hurdle unrelated to patients or being a doctor and focus their learning not on becoming a good doctor but on passing the exam. They work out elaborate schemes to perform well but often will do badly. Q17, you are a senior medical student in NT. The registrar has asked you to take a venous blood sample to assess for anemia. Please demonstrate how you would take blood, treating this rubber arm as if it were your patient. Good students will have sought out many opportunities on the wards to take blood, from time to time asking doctors, nurses, or peers to watch them and check that they are doing it right. They will have become familiar with the different equipment available, including which bottles are used for which tests. They will have learnt rapport with patients when taking their blood, and it is likely that they once forgot to write the patient's details on the sample and had to do them again with many apologies to the poor patient, and so they will never ever do this again. The exam focused students, knowing that the rubber arms used in the exam are not the same as real arms, will have practiced mostly in the skills lab. They will have memorized a list of steps, perhaps from an OSCE book, and practice reciting the steps with robotic reliability, their training and practice. Being focused only on the exam will mean that in real life they are unlikely to be very good. In the exam, even on a rubber arm, these students will perform this skill fluently and professionally. It will be very obvious that they have done it many times before. In the exam, these students will be wooden in their performance and may miss out steps that would be crucial in real life but are less obvious in simulation. This student passes the exam, but more importantly, you will be happy for them to take blood from your favorite arms. This student probably fails the skill or might scrape through, but most importantly, you would not let them anywhere near your favorite art with a needle. Looking at the two examples in Q17, it should be clear that those who strive just to pass the exam, to be OSCE competent, tend to perform worse in the exam than those who strive to become clinically competent and who pass the exam as a side effect. This is a crucial point and cannot be stressed enough. 95% of your learning of clinical and communication skills should be focused on becoming a great doctor, and perhaps 5% should be on exam technique. With a few tips on exam technique and a little bit of practice, you will then fly through the exam. OSCE technique. Having said all this, there are times that students who do fairly well on the wards fall down in the OSCEs, and this section aims to highlight common pitfalls and give some tips in dealing with them. Suspension of disbelief. It is likely that you have watched a film that so engaged you that you felt part of it, that you were unaware of it as a film, but rather that it felt real. At other times, you have watched a film and all you could see were shoddy actors on a screen. In your mind, you may have been critiquing the script, the direction, the soundtrack. It was far from real. There have probably been times that you have tried to move from one of these extremes to another. You noticed that you felt unengaged in the film, and you took some steps to be drawn into it, or perhaps the film was so disturbing that you distanced yourself from what you were watching. Spend a minute and list down things that you have done to help you become drawn into the film, and things that you have done to distance yourself. Go on, do it now. You probably need a break from reading anyway. The OSCE is rather similar. Students who see it as an exam, something synthetic, a game perhaps, tend to have trouble engaging with it. Students who can imagine that each scenario is real, or at least who can suspend their disbelief and approach each station as real, that the actor in front of them is a real patient, tend to do much better. Q18, you are a medical student in general practice. The GP has asked you to take a history from the next patient, Mr. Leo Hill, who has been troubled recently with some chest pain. Please take a focused history in order to make a diagnosis. You have 5 minutes. Student enters the station, shows her name badge to the examiner, and sits down, ensuring that the examiner is out of her line of sight. She introduces herself to the patient and imagines that he is indeed a patient in general practice. She asks him about his pain, and as he is talking, wonders what might be causing it. She naturally asks a blend of open and closed questions and summarizes as she goes along to make sure she understands. She is curious about his thoughts about the cause and she discovers that he is very frightened that it might be from his heart. She can understand why that must be distressing, especially as his brother died recently from a heart attack. All in all, she takes a thorough history from the patient in front of her. She gets a real feel for how his symptoms are affecting him and thinks that she has excluded a cardiac cause and suspects that his symptoms might be due to acid reflux into the esophagus or possibly a stomach ulcer. When the bell goes and it is time to move on, the student is disoriented for a second. She had forgotten that she was in an exam. She gets her thoughts together, thanks the patient, and moves on. Student B enters the station and shows his name badge to the examiner. He notices the examiner holds the mark scheme and he wonders what is written on it. He knows that the first mark is likely to be for introducing himself, so he turns to the actor and introduces himself in the way that he has practiced for the OSCE. He watches the examiner from the corner of his eye to see if he ticks anything off on the mark scheme. And sure enough, it looks like he got a mark for the introduction. Things have started well. He has found out a lot about past questions in this exam and wonders if this is the station from 2007 about cardiac pain or one from 2006 about acid reflux. Knowing that the mark scheme will almost certainly reward using some open questions, he asks, "Can you tell me about the pain?" and notices the examiner moving his pencil on the mark sheet. Another point. The actor says, "Yes, it is quite frightening really. It tends to hurt just here," and points up and down the middle of the chest with the flat of his hand. The student knows that an actor would have been trained to use a fist if the pain was angina or a heart attack, and feels pretty good about himself that he has identified that this is the acid reflux station from 2006. He smiles at the actor and says, "Good." Somewhere else in the exam hall, he hears one of his colleagues saying in a loud voice, "I'd just like to examine your abdomen," and makes a mental note that there will be an abdominal examination station later in the circuit. His smile turns to a grin. He knows he has prepared for abdominal examination. He asks the actor some more questions to show the examiner that he knows the diagnosis. Is it worse when you lie flat? Do you take milk and antacids and Sanjay to make it better? The actor looks a little distressed but nods and the student smiles, seeing the perfect opportunity to gain a mark for empathy, and says, "Yes, I know exactly how distressing this must feel for you." The student finishes early and sits back, trying to hear what the next station will be about. He hears the word warfarin and smiles. The examiner watched the two performances with interest. Our mark scheme rewarded students for taking a patient-centered history, for exploring the symptoms, for exploring all possible causes for chest pain, and for being empathic and reassuring the patient appropriately. The first student did a very nice job, and although she seemed to be less certain of a final diagnosis, she had explored all the right areas to exclude more serious causes of chest pain. She seemed to really care about how the patient felt. She got good marks, and particularly gained marks for being fluent and professional and having a patient-centered approach. The second student did not score so well. Indeed, his behavior was rather odd. He didn't ask the usual questions to exclude possible cardiac causes and seemed to jump straight to one diagnosis, asking nowhere near enough questions to confirm it safely. He smiled in the oddest places. He gained no marks for exploring the nature of the pain and no marks for exploring other possible causes. The examiner felt strongly that this candidate should not pass. The actor was asked to mark each candidate for empathy. Although candidate did not make any empathic statements, it was quite clear to him that she could really understand the patient's perspective, and he scored her highly. He found candidate be rather bizarre. He smiled in odd moments, and although he made an empathic statement, it was clear that there was no empathy behind it at all. He gave him 0 marks. You might think that this example is unrealistic. Unfortunately, you would be wrong. OSCEs are too full of candidates playing the OSCE game and losing out because of it. Look at your list from the exercise earlier. You probably identified some factors around focus and attention. You probably look away from the screen and focus on something typical of real life in order to escape the scenario. You might deliberately over-rationalize what you see, and you might think of other things outside the film to bring you back to reality. To draw yourself in, you might try and forget where you are by ignoring distractions, positioning yourself perhaps to minimize distractions in your line of sight. You might also try and form an emotional connection with what you are watching. Try and get into the lead actor's shoes, see how things are affecting him or her. You can use exactly the same skills in the OSCE, ignore distractions, focus on the patient, and try and ignore the examiner. If you can position them out of your line of sight, all the better. You might want to practice gaining this focus. Perhaps you can role play some stations with your friends. When you get good at throwing yourself into the role required of you, perhaps you can try in environments where there are more distractions, such as the hospital, canteen, or even public transport. If you miss your stop on the train or bus because you were so engaged with finding out what was wrong with your patient, then you will know you are doing well. Consider things that might bring you out of focus, such as the examiner interrupting with a question, and practice how you can learn to manage these distractions and get back into role quickly. Read the question. Okay, this should by now go without saying, but read the question. If you are told to take a history from the patient, don't start examining them, and vice versa. If you are told to explain the mechanism of action, the potential benefits, and the potential side effects of 3 drugs, you could see this as 9 discrete tasks. Don't leave any out. In most OSCEs, you will be given some time to read the task for each station before you enter the station, and there is usually a copy of the task inside the station in case you forget. Examiners are trained not to prompt you, although most examiners will stop you if you start examining a patient's thyroid when you are only expected to talk to the patient, and in these circumstances will usually ask you to read the question again. Managing time. Some students are very good in clinical practice, but when it comes to the OSCE, suddenly struggle because they keep running out of time. They might never have taken a 5-minute focused history in real life, or never just examined the nervous system of the legs in 5 minutes, and so they get stuck. Hello, my name is Peter Mathos. I'm a third-year medical student. I am just preparing for an exam and wondered if you would mind me practicing by testing the nerves of your face. This would involve me just looking at your face, testing how strong the muscles around your head and neck are, and seeing how sensitive to touch your skin is. I'd quite like to do this with my friend timing me for the exam. This is only for my learning, so no problem at all if you say no. Although 95% of your time practicing should be spent on becoming clinically competent, make sure that you spend some time practicing timed scenarios. You can still do this with patients, and if you get a peer to time you and give you feedback, you will learn a lot. You will feel a little rushed first off, but if you get fluent at taking a rapid, effective, focus, patient-centered history and conduct appropriate focus. Diagnostic examinations, you will become a very popular junior doctor, especially in outpatient clinics and and general practice. Knowing triggers that distract you. We worked with a student who had been bullied by a teacher at secondary school. The teacher was a middle-aged woman with a disapproving look who taught gymnastics. She gave such withering, destructive feedback that our student, who wanted so much to do well in gymnastics, was usually brought to tears and eventually gave up. Years later, in her first OSCE, she only had to see that a station had a middle-aged woman examining and she would freeze, heart pounding. She failed all stations where middle-aged women seemed to be judging her. She had some professional counseling and decided to face her fears. On the wards, she would tell female consultants that examiners who looked disapproving tended to put her off in the exam, and asked if they might watch her examining a patient under exam conditions. She became desensitized and went on to do very well indeed in subsequent exams. This example might seem extreme, but we all have triggers that can throw us in exams. Perhaps it is being interrupted in mid-flow or the examiner asking you to skip your usual starting steps of an examination and move straight on to the later steps. Or perhaps it is the examiner yawning or looking uninterested. Whatever does it for you, learn what it is and actively engage in strategies to minimize its effect when you practice. Dealing with brain freeze. Every student's dread in an OSCE is that they will completely dry up. After years of preparation, after seeing hundreds or even thousands of patients, they walk into a station or get halfway through a station and their brain turns to a mush that is barely able to keep them breathing, let alone hold anything that resembles a thought. Mouth open, heart pounding, panic wells up from the guts, but still no thoughts arrive. As we discussed earlier, this is pure and simple stage fright. It is common and, in fact, normal. If you recognize what it is, accept it as normal, and learn to actively manage it, you will be fine. If you pretend it will never happen to you, when it does happen, you will be in trouble. Talk to other people who have done OSCEs at medical school and ask them for tips on managing brain freeze. You could even collate your findings and offer them to others. There are some common strategies that we describe here, but we are sure that you can find out many more. Summarize, it will show that you know what is going on, and usually the next thing to do becomes obvious. For example, if I could just summarize, you got this chest pain last night, it came on after exercise and went down your left arm, and it was crushing in nature, is that right? Can I go on and ask, did anything make it better? Invite questions, this will buy you some time. Will get you saying something sensible rather than just saying and drooling, and might open up some more avenues. For example, I realize that I have been asking you a lot of questions. I wonder if you have any questions or concerns for me. Ask open questions. For example, a simulated patient has just told you that they have a certain disease and you can't quite place the disease for the moment. Your mind has gone blank. Hopefully their answer will trigger you to remember. Gosh, that's interesting. How does the myasthenia gravis tend to affect you? Move to safer ground. Sometimes you might feel uncomfortable or lost on one part of the history, such as the history of the main problem. You might decide to move on to an area that you feel more comfortable in order to gain confidence before going back. Could I just move on and ask you something about your family history? Are both your parents well? This approach can lead to a disjointed consultation. What is better than staring at the patient in silence waiting for the right bit of information to pop into your head? You will need to practice these strategies both with real patients and with friends in simulation so that in an exam, if you get brain freeze, you can quickly grab a semi-automatic rescue strategy without having to expend much thought. Leaving each station behind, you will do badly on some of your OSCE stations. This is a simple fact, and as the final OSCE marks tend to be averaged across all the stations, you can afford to do badly in a few stations. Some students do badly in a station and then can't think of anything except their station. They keep thinking back about other things that they could have said or done, and as a result, they underperform on the next station and then the next station. The simple truth is that students rarely know how they did on a station. Basic skills such as examining a patient's respiratory system usually have a high pass mark. Students leave these stations thinking they did well, but actually didn't do as well as would be expected. In contrast, students often leave really challenging stations thinking they have done badly, but actually they were not expected to do well, so the pass mark for that station might be very low. You might well fail stations that you think you did well in and pass stations that you think you did badly in. Some students find it quite challenging moving from thinking about one skill straight into thinking about another with very little time in between. Practice a few 5-minute skills in a row and get used to going from one skill to a completely different skill. It can be disorienting the first couple of times. Start a ritual that will help you leave each station behind you and allow you to focus on the next task in hand. Make it a ritual that is personal to you. Perhaps at each new station you smile and shake hands with the examiner or patient. Perhaps you can see the ritual of introducing yourself as in some way purifying you from the last station. You might find some physical stress relief techniques to help, such as clenching your fist really tightly, feeling all the tension go into that fist. Feel it getting tighter and then shaking it loose, feeling the tension dissipate. Breathing exercises, brief visualizations, there are endless possibilities. Find something that works for you and practice it until you can do it automatically when stressed. Saying I don't know. Every day, senior clinicians say I don't know to patients. The thing that differentiates them from junior medical students is that they tend to say something along the line of I don't know, or let me find out some more information from you and then this is my plan for finding out and getting back to you. What doctors do not do is lie to patients, make things up in order to answer their questions. Imagine the following OSCE station. Q19, you are a senior medical student on a surgery attachment. Your team is referring the next patient for an upper gastrointestinal endoscopy. Please explain the procedure to the patient. Student C, hello there, my name is. I understand that you have been referred for an endoscopy and I have been asked to come and explain it to you. I must say that I am not an expert on this subject, but I thought that I could find out what you understand already and what your main questions are. Then I could explain as best I can, and if there are any outstanding questions, I will either find out myself and come back to you, or I will ask one of my seniors to come and talk to you. Would that be all right? Student D, well, yes, an endoscopy, well, we will pass a big telescope down your throat, but don't worry, you will be put to sleep first, and we will keep you in overnight to make sure you are okay afterward, yes. Risk, well, no risk at all, very safe, unless, well, no, it is completely safe. For some reason, some students think that it is okay to lie in an OSCE. True enough, saying I don't know and sitting silent for the next 4 minutes and 50 seconds doesn't do you any favors. But admitting uncertainty, finding out the patient's perspective and prior knowledge and proposing a plan for getting the information that you don't know back to the patient really well. Pulling it together. The last section on OSCE has been lengthy, but only really has 2 messages. The first is to throw yourself into the role as if each station is a real-life scenario. Read the student brief for the station and imagine that it is true. Try and avoid the temptation to second-guess the examiner. The second is to consider possible challenges for you in the exam and ensure that as well as practicing in order to be a competent doctor, you also spend a little time practicing OSCE technique with your peers. The Viva. As we mentioned before, Vivas are getting less common these days. Knowing the structure and format helps. Probably the most important skill in answering a Viva is to structure your answer well. Q20, tell me about ruptured ectopic pregnancy. Student P, well, it's where pregnancy forms in the fallopian tube, usually around 6 weeks of pregnancy, it can be quite dangerous. Student Q, ruptured ectopic pregnancy is a gynecological emergency. It is managed by making a rapid diagnosis through history, examination, and special investigations carried out while concurrently resuscitating the patient, followed by emergency surgical treatment. The features on the history that would identify this diagnosis would be In this example, student P has actually given more hard facts than student Q. But student Q has started with confidence, has set the scene, and has laid out a plan for continuing to answer the question. Through giving this answer and signposting each time he moves on to a separate part of the answer, he will convince the examiner that he is a clear thinker who understands the information. Some examiners might even move him on after that introduction to another topic, believing that he has already demonstrated that he knows more than enough about this topic. If viewers are likely in your curriculum, it would be a good idea to get plenty of practice by recording yourself to practice fluency and structuring your answers, using your peers to practice answering unexpected questions, and using any faculty who have experience in viewing to practice how you would handle it in real life. Developing these skills will be useful in later life for job interviews, etc. Summary: Chapters 10 and 11 have tried to highlight some of the common pitfalls found in assessment at medical school and how to avoid them. Good exam technique in no way replaces appropriate learning, but rather goes hand in hand with it. Hopefully, the tone of this book in general and the section on OSCEs in particular has highlighted that the purpose of medical school is to prepare you to become an excellent doctor. Exams are part of that journey, but should not be seen as the destination.